So let us quickly learn to draw the sagittal section through the brainstem. And this is the corpus callosum, the fornix. Here is the pituitary gland, and here is the pineal body. This goes into the midbrain. Here you have the two corpora quadrigemina, the superior and inferior colliculus. Then you have the pons and the medulla. From the midbrain, there is a pedicle which goes to the cerebellum, and from the medulla also there is a pedicle that goes to the cerebellum, and from the pons also there is a pedicle which goes to the cerebellum. We'll make these pedicles again. The midbrain one, the pons one is coming from the side, and the medulla one. So three cerebellar peduncles, and on this hangs the cerebellum. There is a tentorium cerebelli in between, and above you have the occipital cortex going up like this and coming on this side. You have the frontal cortex. Okay. Now, if on this diagram we want to tell you that the third nerve will be at the level of the superior colliculus, and along it will travel the parasympathetic fibers of the Edinger-Westphal nucleus. The fourth nerve will be at the level of the inferior colliculus, and then there will be a sixth nerve, and the seventh nerve fibers will turn around the sixth nerve, and then both will emerge like this. The sixth will rise up, will cross this bone, and this is called as the bend of wolf, will lie in the cavernous sinus, lateral to the artery, will enter the superior orbital fissure, and will supply the lateral rectus. Supply the lateral rectus going to the eyeball. This is the lateral rectus, and this lateral rectus is getting inserted like this, supplied by the, here will be the superior rectus, here will be the inferior rectus, and the medial rectus will be that side. So this is the sixth nerve, and now we'll come to the, if there is a supratentorial space occupying lesion, supposing there is a lesion here, it will press the tentorium cerebelli and it will press the brainstem, and this nerve will get stretched here at the bend of wolf, and the lateral rectus will be paralyzed. So in head injuries, when the patient is unconscious, you test the lateral rectus by rolling the forehead from side to side, and that's called as doll's eye movement. So we had finished the sixth nerve, and now we'll go on to the seventh. This is how the seventh arises. It winds round the sixth nerve, creating a colliculus, which is the facial colliculus here in the floor of the fourth ventricle. If you see those colliculus, you will be able to distinguish that above them is the pons, below them is the medulla oblongata. And then it also carries parasympathetic fibers from the superior salivary nucleus. Now we'll make another diagram. The internal occipital protuberance, then the anterocranial fossa, the anteroclinoid process, the lesser wing of sphenoid, the the gestagelli, the foramen cecum, the cribriform plate, the orbital ports of the frontal bone, the petrous temporal, posterior clinoid processes, and we are now, here is the foramen magnum, the occipital condyles, and the sixth nerve. This dorsum sali is the place where the pons is resting. The sixth nerve has climbed on this, passed under this petrosphenoid ligament of Guber, gone into the cavernous sinus, and then through the superior orbital fissure, which is here. It has gone through the superior orbital fissure, and it has supplied the lateral rectus. It has supplied the lateral rectus. Okay. Then there is the internal acoustic meatus. So there is the internal acoustic meatus here. The seventh nerve, as it emerges, seventh nerve emerges from the pons below the sixth, passes like this into the internal acoustic meatus. It is accompanied by the anterior inferior cerebellar artery, which goes and comes out and supplies the cerebellum. It is also accompanied by the ductus endolymphaticus, and it is also accompanied by the eighth nerve. So the structures that pass through the internal acoustic meatus are the seventh, the eighth, vestibulocochlear, and with the seventh, are carrying the parasympathetic fibers. So the parasympathetic portion of the seventh is sometimes referred to as the 13th cranial nerve or nervus intermedius. Then eighth has also two components, the vestibular and the cochlear, the hearing and the balance. And then you have the anti-inferior cerebellar artery entering and then coming out and supplying the cerebellum. And then finally you have a ductus endolymphaticus, which connects the internal ear space to the cerebrospinal fluid, so that if this is blocked, then the pressure in the vestibule rise and it leads to vertigo. That is called as Meniere's syndrome. So these are the structures that pass into the internal acoustic meatus. Now, after the internal acoustic meatus, the nerve comes to lie against this box type structure, This box is the middle ear. So this middle ear has got a superior surface, has got an inferior surface. So it has got a superior and inferior surface. Then it has got a lateral and medial surface. Then it has got an anterior and posterior surface. Right? On the lateral surface is the tympanic membrane. Outside this is the external ear, and the sound waves are making this tympanic membrane vibrate. So they are making this tympanic membrane vibrate, and the center of the tympanic membrane, which is called as the umbo, is connected by a malleus bone, a incus bone, and a stapes, stapedius bone, to a oval and a round window on the medial wall of the middle ear, against which rests the cochlea, of the middle ear. So there is a cochlea, there is a vestibule which is connected to the ductus endolymphaticus, which fills this, and then there are semicircular canals. The semicircular canals convey balance, and the cochlear, the sound, and the vestibulocochlear nerve supplies this cochlea, the eighth nerve. Eighth nerve, coming in the internal acoustic meatus, supplies this cochlea, and the vestibular part of it supplies the semicircular canal. So vestibulocochlear nerve, the eighth nerve, enters the internal acoustic meatus and ends in this cochlea, which is lying on the medial wall. Now let's see the seventh nerve. The seventh nerve is coming on the supero-anterior part of the internal acoustic meatus. It's coming here. Supposing this was the internal acoustic meatus, the nerve is coming on this portion. It's coming on the antero-superior portion. It strikes the medial wall, turns back. This turning back is called as the genu. Genu means the knee. Then it strikes the posterior wall, traverses the posterior wall like this, obliquely, and emerges out of the stylomastoid foramen. Goes out through the stylomastoid foramen, just parallel to the styloid process. Now, there is the parasympathetic fibers running with it, the nervus intermedius. This nervus intermedius collides with this and becomes a ganglion. It becomes a ganglion which is called as the geniculate ganglion. Now these geniculate ganglions, some fiber run like this, then like this, and from here they emerge pass between the malleus, incus and stapes and emerge out of the anterior wall to become the chorda tympani. The chorda tympani connects with the lingual nerve, lingual branch of the mandibular nerve, supplies the tongue, and along with these parasympathetic fibers, it also carries taste. So the taste fibers are going backwards and the parasympathetic fibers are going forward. So the chorda tympani. Then from this geniculate ganglion arise petrosal nerves. You see, this is the petrosal bone, and if we make the petrous bone like this, then this is the skull boundary going back, and here you have the middle cranial fossa, and the fifth, this impression is the trigeminal impression. Here lying the trigeminal ganglion, having the ophthalmic maxillary and mandibular nerve emerging from it, and under this trigeminal ganglion there is a bony surface which is the impression of the trigeminal ganglion. On this are two foramen. Actually they are hiatus, and the seventh nerve has come like this, turned back, turned down, and has emerged from the stylomastoid foramen. So here the nervus intermedius component of the nerve has become the geniculate ganglion. A part of it has gone with the facial nerve and has become the chorda tympani outside. But from the geniculate ganglion, these two hiatus connecting these two openings are hiatus. So these two hiatus let the lesser and greater superficial petrosal nerve emerge from them. So in the trigeminal impression, you have two hiatus from which emerge the greater and lesser superficial petrosal nerve. Now, supposing it is the lesser superficial petrosal nerve, it will get out through the foramen ovale. Male will pass through ovale, mandibular nerve, accessory meningeal artery, lesser superficial petrosal nerve, and imagery vein. So this nerve will emerge out of this parasympathetic branch. Lesser superficial petrosal will emerge out like this, will mount on the mandibular nerve, go to its auriculotemporal branch outside the cranium and supply the parotid. The greater superficial petrosal nerve fibers will go like this, will emerge out of the foramen lacerum through which the internal carotid artery is entering. Now along the internal carotid artery is the sympathetic. So now it will become both sympathetic, we'll make this sympathetic red, and do is the parasympathetic. So now it will combine greater superficial petrosal nerve will combine with the sympathetic fibers around the internal carotid artery and they will become the here somewhere they'll pass through a canal which is called as the pterygoid canal. They'll become the deep petrosal nerve and they will relay in the pterygopalatine ganglion. From pterygopalatine ganglion, there's foramen rotundum through which the maxillary nerve is coming and entering the orbit through the inferior orbital fissure and emerging as the infraorbital nerve. Now they will then, these fibers will hike onto this maxillary nerve, get onto its zygomatico-temporal branch. There is zygomatico-facial and zygomatico-temporal branch. Then they will, the ophthalmic is divided into three: the lacrimal, the frontal, and the nasociliary. That's the ophthalmic. So they'll then hike on to the lacrimal branch of the ophthalmic and supply the lacrimal gland. So you are asked the nerve supply of the lacrimal gland. So superior salivary nucleus, facial nerve, geniculate ganglion, greater superficial petrosal nerve, we'll say. Superior salivary nucleus, seventh nerve, geniculate ganglion, greater superficial petrosal nerve, deep petrosal nerve, pterygopalatine fossa में ganglion, then maxillary nerve, that means fifth B, then zygomatico-temporal branch communicates with lacrimal branch of ophthalmic and supplies the lacrimal gland. And the other thing is from the geniculate ganglion, same parasympathetic fibers, lesser superficial petrosal nerve emerges out of foramen ovale, joins mandibular, auriculotemporal branch of mandibular and goes to the parotid. Then the other fibers which keep accompanying the facial nerve as it lies in the posterior wall, from there emerges the chorda tympani, passes between malleus and incus, emerges out of the anterior wall of the middle ear, lies just medial to sphenomandibular ligament. So there's a, on the greater wing there is a projection which is called as the spine of sphenoid. So from that spine of sphenoid there is a sphenomandibular ligament. So if you want to find where the chorda tympani nerve is in the infratemporal fossa, feel for the spine of sphenoid. And then it hikes onto the lingual nerve and then it reaches the tongue, and to tongue it supplies taste, is the sensation, but it also supplies the sublingual and submandibular glands. That's the parasympathetic supply. So I think after that the facial nerve would emerge. Out of the stylomastoid foramen, and as it emerges out of the stylomastoid foramen, it encounters a gland here, which is the parotid gland. So it lies in the parotid gland, divides into a zygomaticotemporal, into a temporal branch and a facial branch, and then 3 branches below, 5 branches, and they are the infrazygomatic, mandibular, and cervical. So zygomatic, facial, and cervical. So these are the branches of the motor branches of the facial nerve, and they supply the face. Now, as if the nerve gets thickened in this stylomastoid foramen, there is a paralysis of these muscles, and that is called as facial palsy. And this type of facial palsy, which is because of this swelling, is called as Bell's palsy. So there can be a Bell's palsy which is from this point, and there can be a paralysis of the facial muscles which is supranuclear, from above the facial nucleus. So there is a supranuclear and a infranuclear paralysis of the facial nerve. The supranuclear paralysis would spare the frontalis muscle. Frontalis will be spared. Therefore, the person will be able to raise his eyebrow. In infranuclear paralysis, frontalis will be involved. So in Bell's palsy, frontalis is involved. Now, the major problem with the facial palsy is that the orbicularis oris muscle is not able to close the eyelid. Orbicularis oculi muscle is not able to close the eyelid, and therefore there is corneal opacity. You see this a lot in leprosy. What you can do is that you can take the anterior fibers of the temporalis muscle and put them into the orbicularis oculi. So temporalis to orbicularis oculi will ensure shutting of the eye. Because tightening the temporalis by clenching your jaw may also make you close your eyes. So these two muscles, the temporalis and orbicularis oculi, act in the same phase. So they are synphasic muscles. And sometimes, every time you clench your jaw, the eye will close. Now, that is too much of synphasic action, and when that is too much, this phenomenon is called as Marcus Gunz phenomenon. So, I think after this much of this, you will be able to answer most MCQs on the facial nerve. Thank you.